Today we have Mr. Bobby English. He is the owner and founder of Optimum Personal Care in Missouri City. They have two locations, one in Missouri City and one in Sugar Land. So we'll be hearing from Bobby about his getting started into the industry and what has kept him motivated, or also towards the future, what his plans are. So welcome, Bobby, to Senior Living with Syed.
For having me. I really appreciate you coming out and giving us this opportunity to speak, I guess, to the world. My name is Bobby English. I am the owner operator of Optimum Personal Care. We actually have two locations. We have the original locations in Missouri City. We house 40 residents there, and we have our Sugar Land location. We currently have phase one that's operational now with 28 beds, and hopefully by December 20th, we're hoping to have our certificate of occupancy for our phase two for another 28 beds, so give us a total of 56 beds. Actually, I've been in the business, actually January 2020 will be 25 years in assisted living. And how I got started is kind of funny. I graduated from Texas Southern University with a marketing degree, and after graduation, I started working for the Shell Oil Company. And a lot of people ask me how did I go from Shell Oil to social work? And quite frankly, my godmother, who was a social worker, she was dean of social work at USC in California, and she was down here on holiday once, and she challenged me because I had made some comment about how much I love the elderly and would love to work with the elderly. And she said, well, why don't you go back to school and get your social work degree? And that was like an epiphany for me. And I said, yeah, I could do that. And so at the time, Shell had me working in New Orleans, and I was doing running purchasing through what we call the Gulf Coast region, and I really wanted to get back home. And so finally I was able to convince management to send me back to Houston, and as soon as I did, I enrolled in a community college. HCC had a program for geriatric certificate, and so I did that with the idea of that I would go ahead and start graduate school at University of Houston, social work, and with a concentration in gerontology. In 1995, when I finished school, again, that paradigm was you had smaller homes, and then you had individuals that were in the business, and then they would start taking care of folks. But they had all types of dementia, and typically it was difficult for us. At that time, we were called personal care homes, and as a personal care home, we really didn't have the budget that to compete with a Brookdale community, with a true assisted living that you typically think about. So as a personal care home, we tend to take care of residents needing a little bit more care that don't necessarily fit into the box, if you will, of a large community. And so in doing so, our emphasis is geared more towards the care. And then what I found, though, is that, as I mentioned before, is that in taking care of folks with dementia, smaller is better. But you need the numbers from the business side to have the economies of scale, if you will, and to make a living for it, and basically just keep the lights on and provide good quality care. One of the things that we've developed in our model is what we call the palliative model. What that means is that you have an individual, and it's individual, it's resident by resident. And if you notice, I say resident, but there's a team that takes care of my residents on the skill side, the medical side. So we have a physician who's supervised by a nurse practitioner who writes orders for my residents requiring short-term skill needs, whether that be physical therapy, occupational therapy, dental, if you will, dietitian. Everything is encompassed in that care plan. And so we're small enough that I can literally tailor make a care plan for an individual, as opposed to, say, in the large communities, typically there you have 100, 150 people, and so there's only so much tailoring you can do in that large environment. But having a small home-like environment that we've developed is easier to do that. And because of the way the homes are structured in a duplex model, I can take like people and put them together. And so if someone's having negative behaviors with their dementia, I'm able to group them together and have my caregivers trained specifically to deal with those individuals and those needs. Because as you know, when you're dealing with folks in dementia, you're in their reality. They're not in our reality. So it would behoove you to really focus in and to hear and listen and to understand what true dementia care is. When that family comes in, we sit down with the family and we kind of get a good feel as to the needs and the diagnosis and what would be involved in the care plan. One of the things that we don't do, we're not for everybody. I tell families if bingo is primary to care, you're probably looking for a more traditional assisted living. But when the care trumps the bingo, then you're probably in the right spot. We get a lot of fees from the large communities because their design and their model is such that they take care of people to a certain level and they don't go into the higher acuity. What we do here at Optimum Personal Care is our standard is during the daytime we run a 1-to-5 ratio of care. At night we run a 1-to-7 ratio of care. We have an RN that delegates to my non-licensed staff so that they can be able to do certain skill sets that will be required to take care of someone. So it's very important that we get that right, because the worst thing you can do is to invite someone to come live with you and you're unable to take care of them. And then they have to move. It's so unfair to that individual, to the family, and quite frankly, to the current residents that you have. Families contract me for the custodial piece, the bathing, the dressing, the grooming, the medications, laundry, and food preparation. And then we also have the skills side where we've had RNs, LVNs to help us communicate to those skill providers as to what possibly this resident needs. So my staff is trained to observe change of conditions. And when there's a change of condition, we immediately call our NP, our nurse practitioner, or our physician, and we give them a report. In turn, they're training us to look for certain signs and symptoms of an individual so that we're always talking and communicating. It's so important, I can't emphasize that enough, that when you're dealing with someone with dementia, it's very dynamic. Something as simple as a urinary tract infection or a common cold can develop and exacerbate into something that's very serious, and then you're having to go to a hospital situation, and it can be very well prevented if we've done some front-end work and identifying certain signs and symptoms that you and I pretty much take for granted, but for an elderly person it could be very major. So I think that's very important and very key to understanding exactly what we do and how we do it. When I got out of school, the thought was that I was going to develop this low-cost quality model. And I found out very quickly that's an oxymoron that just doesn't exist. You either have the quality or you don't. But what I have been able to do is to develop a program whereby I feel we take care of individuals. I call them the 99 percenters. There's a group of people, that 1% that it doesn't matter what the cost is, that we can afford it. But I like to concentrate on the 99%, those retired school teachers, oil field workers, postal workers, federal workers who have a decent pension that could afford this level of care. And because our emphasis is more about the care piece, so a lot of what we do, we put forth towards that in terms of dollars, that's why we run the ratios that we do. But my grandmothers wouldn't have been able to afford to live if I wasn't in this business, to live in an assisted living home like they died in. They most probably would have lived in a nursing home environment. Nothing against nursing homes, because we all have our space on that aging continuum, but most people would prefer if they could, to live more in a home-like environment as long as they possibly can. And that's what we've been able to do and develop that. With me, it hadn't been about Bobby English for years now. It's really about my staff. It's really about the folks that we work together and we support each other and we have the same philosophy in terms of quality of care, that there's zero tolerance for abuse and neglect. And quite honestly, in 25 years, I can honestly say, my banker's not going to like this, but it's the truth, is that we've never lost anybody to money. And not that I can just take care of people for free, because that's impossible, but we've always found a way to make it work. And so in my retirement, what I like to do is I'm going to be focusing more in helping the industry, how I could be more effective in changing the industry, more for the universe than more than just for me or for OPC. One of the things that I'm going to champion is that I want to create an OPC community, and I want that to be a nonprofit, and I want to invite young students to come in with their bright ideas of wanting to change the world like I was 25 years ago and to make a difference. But in doing that, by giving me their talents, I want to be able to make school affordable for them. So we'll create a foundation, and so we'll have firsthand these youngsters, as I say, come in. I want to give them the answers to the test, and I want them to challenge us with questions as to why and why not, and figure out how we can make this happen, and how we can do a collaborative approach between government, church, and state, and individuals, and all coming together and defining what true quality care is at a certain level, because as you know, all our licenses are built on minimum standards, and so I want to kind of define what quality care is, so that and make it affordable to more people.